on atrial fibrillation management for atrial fibrillation based on the evidence and based also in the news those new trials closure and champion AF. So the first paper finding the association of atrial fibrillation with stroke was in 1933 from Harvard Medical School, Boston Scientific, Boston City Hospital. This Dr. Soma Weiss, he found the association between auricular fibrillation and the formation of mural thrombi. Then in 1942, that was also like a paper describing that not only atrial fibrillation was associated with the development of auricular mural thrombosis, also advancing age. And in cases of mitral stenosis, that was done. The paper was written in 1942. Then in 1950, there was another paper that is interesting because they already recommended how to manage those patients prophylactically. And look, termination of fibrillation with use of quinidine, meaning use of antiarrhythmic, surgical resection of auricular appendage, and long-term continuous anticoagulation therapy. Basically, by 1950, they already knew how to treat this disease. And that's why, like, contemporarily, we use the same approach. They also described two cases that they classify as idiopathic auricular fibrillation without underlying heart disease. This was a new thing at that point. Why? Because most of those cases were related to rheumatic heart disease. The anticoagulation used at that point was dicuramol. Dicuramol in 1950s, in the 1950s, that was discovered in the 1930s, but called Paul Link, and later he, from this medication, he discovered the warfarin that is widely used. Then in 1949, 1 year later, there was like the first paper by Dr. John Maiden describing we can do prophylaxis, a closure, surgical, a closure of the left atrial appendage. And he described also in this patient that most of the thrombi comes from the appendix instead of the left auricle. This was like a huge thing at that point. Then in 1950, also like from Boston, Massachusetts, they described 194 patients. And what they found that this was more common in females and was most likely associated with mitral stenosis, also a combination of mitral stenosis and stenosis and other valvulopathies. And they found like not only in the left appendage of the left atrium, although was common, was also in the cavity of the left atrium. Why is this important? Because later on you're going to understand why. Then in 1987, the Framingham study, they already was evidence for looking like atrial fibrillation without any valvular disease was related to a stroke. Remember, in 1950, most of the cases were related to rheumatic heart disease, but the Framingham study already confirmed atrial fibrillation by itself increased the risk of bleeding, and also at that point, like they believe, like also was associated with hypertension that was related to that, but a Framingham study confirmed that atrial fibrillation by itself increased the risk of stroke. They find like they like describe something interesting at that point that there was no trial that they compare warfarin in the prevention of the stroke. So they recommend in 1987, like please do a trial showing that warfarin is beneficial for those patients with atrial fibrillation. So that's why, like in 1990, BATAF was the first trial that they compared warfarin. What they found that was beneficial, warfarin in the preventing of stroke in non-rheumatic atrial fibrillation. Then in 2007, they did like a meta-analysis comparing all the trials up until this point. What they found is that warfarin was beneficial versus placebo as well as antiplatelet aspirin. And what they found that warfarin was even better than aspirin. And they found like 60% reduction with warfarin and 20% reduction with aspirin. That's what like, at that point like guidelines they used to say like you had like low CHAS score recommend aspirin, you have a higher risk score, recommend warfarin. You are going to see in the textbook even. But there was a trial from Japan, and the trial said like aspirin is not that good. It's comparable to placebo. That's why like the recommendation was updated, and this was in 2006. This trial that there is no beneficial aspirin for patients with atrial fibrillation. That's why like right now in low risk stroke we don't recommend atrial fibrillation. And this also like look in the meta-analysis, although like 90% reduction, there was no statistically significant. I increased the risk of bleeding. That's why like aspirin is not recommended. Also, like in 2009, there was this trial, active trial, that they compared clopidogrel added to aspirin. Although they found a reduction on the stroke risk, they increased the risk of major bleeding. That's why like um, antiplatelet therapy is not recommended for atrial fibrillation, for prevention of a stroke in atrial fibrillation. Now, no vitamin K oral anticoagulation, dabigatran, apixaban, rivaroxaban, edoxaban. Look, in 1995, this was the first inhibitor of thrombin, inogatran. This was an IV. From this, melagatran was developed. This was oral, and from this, cimelacatran was developed. This is similar to dabigatran. This paper show like it was beneficial, cimergatran. However, this was discontinued from the market. Why? Because in 2006 they found like enough evidence that caused liver toxicity. So Europe withdrew this medication for the market. That's why like you don't see that nowadays. Then in 2009 there was the first trial comparing dabigatran versus warfarin. This was a RELY study. Remember, up to 2009, the only medication that we have evidence was warfarin that prevent the risk of stroke. And what they found, they compared like two doses, 110 and 150. 110 was associated with rates of stroke or systemic embolism that were similar to warfarin and lower rates of major hemorrhage. And 150 was associated with lower rates of stroke or systemic embolism but similar rates of major hemorrhage. That was in 2009. Then in September 8, 2011, rivaroxaban came. There was like a trial, Rocket AF, that was published, and they found like was non-inferior to warfarin, and there was no significant between group difference in the risk of major bleeding, although intercranial and fatal bleeding was less frequently in rivaroxaban group. However, like a few days after, in September 5, Eliquis came and said like this was even superior and caused less bleeding and lower mortality risk. So up to this point, we had like the bigger time that was similar, uh, non-inferior to warfarin, less risk of bleeding, depending on the dose, or similar risk of bleeding. Was Xarelto, non-inferior, and apixaban that was even superior. So up to this point, like it changed the game. Now we had like oral anticoagulation that didn't require any like a frequent blood work. Edoxaban also came based on the Engage, but this is mostly used in Japan. That was that they found like in 2013 that was a non-inferior to warfarin that is not used frequently in the States. However, so far they found like interesting evidence that those new oral anticoagulations trials excluded patients with history of major hemorrhage, and 20 to 30% of those patients are gonna discontinue the treatment up 2 years. So meaning if you prescribe those medications in 2 years, one or three are gonna discontinue those medications. And what do you do with those patients who have like higher history of major hemorrhage? You discontinue the anticoagulation, yes, but do you have like something beneficial or not? That was like in their mind, we need something else. That's what like 2002 in circulation there was published the first device that was based on California, and that device was called a percutaneous left atrial appendage transcatheter occlusion. This was in 2002 the first percutaneous device that was feasible to perform, and this was the device you can see there. It was the angiographical views. And this device, unfortunately, they didn't get a FDA approval. But in 2007, this company, Atrial, they came with, they evaluating more than 700 patients, this Watchman device. And they found like, oh, it was doable and was safe to do this procedure. This was acquired by Boston Scientific in 2011. And in 2014, 3 years after they acquired this company and this device, they came out with like Protect AF. Protect AF was a comparison of this device, percutaneous left atrial appendage, versus warfarin. They followed the patient for 3.8 years. And what they found? They found that this was not only non-inferior, but was also superior for cardiovascular and all-cause mortality. We're going to analyze the data if this is the case or not. They included patients with CHAS score of more than 1, and they followed from 2005 to 2008, up to October 2011. Remember, the Boston Scientific was bought like in 2011, so this trial was before this company was acquired. The non-inferiority was required to be 98.7% and superiority more than 95%, and non-inferiority margin was based on 2.0. This was like just like the patients, 700 patients randomized, 400 to the device, 200 to the control group. And what was the design was from the device day until 45 days, they recommended warfarin plus aspirin. And then after that, they did like a TE if the device was sealed. Sealed meaning like less than 5 millimeters, the perivascular leak. They recommended like to discontinue warfarin and continue just with aspirin. And here is interesting because most of the patients look 33, 33% of the patients with a CHAS-VAD score of 1. So meaning like if you put this device in patients who has one paroxysmal atrial fibrillation, meaning no in a lot of time in atrial fibrillation, has a low risk of stroke, the patient is not going to have like a lot of events. It's like putting like in a 20-year-old who you know like he's not going to have like a lot of like a stroke events. It's going to show like no inferiority, right? But different is to put in patients who have a high risk of stroke development. Then it's different. Then you are gonna see like if this device is working or not. And look, 40% was in paroxysmal. So paroxysmal meaning less than 7 days. I can be in 6 hours in atrial fibrillation. It's different like to be in 10 days in atrial fibrillation. The risk of developing a stroke is different. And they found like a non-inferiority and superiority, but this also like they described like there was almost 4.8% in serious pericardial effusion. There was like almost 5% of a peri-procedure risk. So with this evidence, they went to the FDA, and the FDA told them basically, we cannot approve this device to be used in the United States. We need more evidence. Why is that? Because those patients, including a Protect AF, was low risk for event patients, just by the score of 1, like 30% of the patients. So meaning like patients who didn't have like a low risk to develop like those clots. You're not gonna have like evidence. You're not gonna have like enough evidence to show like the device is actually working. Also was 5% of almost 5% of risk of like a device like a procedural risk. So obviously Boston Scientific said like we are gonna develop like another trial, and that trial was called Prevail trial. Prevail trial was only done for the FDA, as you are gonna see in the next slide. And what they found was non-inferior to warfarin in stroke prevention or systemic embolism after 7 days. But no inferiority was not met when they included this 7 days. Procedural safety was significantly improved. So they now include a CHAS-VAD score of more than 2 or 1 with another risk factor. Basically, CHAS score more than 2 or more than 1 with another eligible risk factor, meaning being more than 75, basically like CHADS score. They only did in 50 sites in the United States. This was only directed to the FDA. You're going to see why. And they show like, look, CHADS score of 1 just was like 0% almost in both groups. So though in this trial, no like low risk patients were included in this trial. And also, like, there is interesting that almost 40% was done in new sites. So what does that mean? Like, those devices is pretty easable to teach new operators. What was the design? They, again, from the day to implant to 45 days, they recommend the warfarin implant aspirin. At 45 days, they recommended to do a TE. The TE, if that device was found to be sealed, they recommended to stop warfarin and to continue aspirin and plaques. After 6 months, just continue with aspirin 325. What they found, unfortunately, they based like the non-inferiority 1.75, and they overpassed 1.89. So was non-inferior for the co-primary efficacy endpoint for stroke, systemic embolism, cardiovascular, and spleen death. So what they did is they excluded those 7 days, and they put it like the non-inferiority margin to 0.0275, and they found non-inferiority was met because it was 0.0273, and they found like it was non-inferior for this trial. They also like did like the safety events, and what they found a was a good performance because like the point was like 2.67, and they found like a 2.65. So safety was met based on the trial here. And they comparing like between Protect AF, Prevail, and the CAP registry. They really want to show like the CHADS score. The patients had like a higher CHADS score and were older patients with a p-value statistically significant. That was like the main objective, showing to the FDA, look, this trial was done in patients who had like higher risk of stroke, and the safety also of the procedure was also greater than the prior trials. Implant success was also improved from 90 to 95%, and the complication at 7 days was also improved. Remember, in Protect was so like show like 8.7, and the Prevail almost half, 4.5%. Overall success was 95%. And they said like, why we didn't find like no inferiority in the trial, in the overall trial. And they compare with the prior trials for like those new oral anticoagulations. They said like most of the time in those trials, the patient was in time therapeutic range was 64, 62, 54, 55. But versus in the Prevail trial, most of the patients were in therapeutic range 68%. What does that mean? The most of the patients were in therapeutic range. So the risk of developing stroke is less. That is why like we are not gonna find a lot of patients in the control group who develop the stroke. That's why like we didn't find no inferiority. Why is that? Because if the patients were in therapeutic range less, so there is more risk of developing the stroke. So then we can see the non-inferiority. They are alleged to that could be like one of the causes. Uh, Now, until that point, FDA 2015 approved the Watchman to be commercialized in the States based on the evidence. There is two types of devices now that we have like from Watchman. 2.5, that was the original, as you can see there, and Watchman Flex. Watchman Flex is the new device. And Watchman Flex was approved in 2020, FDA approval. Remember, Watchman 2.5 in 2015. Euro approval is the CE mark. It was way back 2005 for the 2.5 and 2011 from the Flex, for the Flex. This is all the device that we have. You can see there is like the most used is Amulet Abbott, and we're gonna see there the next slide. So Abbott is the another company This Abbott acquired St. Jude. St. Jude had like a device, ACP, and they developed from this ACP this amulet device that got FDA approval in 2021 after this trial, IDE trial. What was the IDE trial? They compared them versus Watchman. And what they found, the amulet was non-inferior for safety and effectiveness for stroke prevention for no valvular atrial fibrillation, and was even superior to for LA occlusion. However, the amulet had like more procedure-related complications than the Watchman device, but was approved. Uh, this is the size they found like the evidence that the amulet was non-inferior, however had like more procedural risk, however had like a less residual jet 45 days versus the Watchman device. Now we are gonna talk about the current data, Closure AF and Champion AF. In March, there was two trials that came to life, to like the public, available to the public. And this changed a lot. Why? Closure AF was published in March 18. Champion was published in March 28 in the ACC. Closure AF, they basically studied patients with atrial fibrillation and high risk of stroke and bleeding. And they found like to be not non-inferior, meaning like doesn't work. Versus Champion, they found like was non-inferior to NOAC. Remember, look, Closure was done in Germany versus this other trial was done like in multiple countries, and that was also funded by Boston Scientific. The other was not funded by like any industry. Closure AF was a prospective multicenter randomized, was done just in Germany, was from 2018 May 2024, 42 sites. What was the inclusion criteria? Was high risk stroke, high risk of bleeding. What was the trial intervention? They included all the devices, Watchman, Amulet, and all the operators has to be experienced in putting those devices. What was the design? They did like that for 3 months. They discontinued that. If the TE at 3 months showed like a peri leak of less than 5 millimeters or was completely closure, and they discontinued aspirin after 6 months. And also like in the control group, the physician could choose whatever like DOAC that he could consider was like the best for the patient. What was the primary endpoint? Was a composite for stroke, major bleeding, cardiovascular, or unexplained death. A secondary endpoint was like the components of this composite primary endpoint. What was the statistical analysis? It was intention to treat analysis, meaning all the patients for each group was analyzed. The hazard ratio was put it like 1.3 for non-inferiority margin. And the recruitment, they initially were planning to recruit like 1,500 patients, 1,586 patients. However, like they only recruited 900 patients, 912 patients. Why? Because there was in between another trial, that was the Prague trial. They compared and they found like this device was not inferior to DOAC. That's why like they come out with like less patients in the Closure AF trial. What was those patients' characteristics? This is important because the CHA2DS2-VASc score was 5, the mean. Those patients had like a higher risk of stroke. And Lux Half-Blood score was 3, so those patients had like higher risk of bleeding. So those patients, first of all, has higher risk of stroke and higher risk of bleeding. Those patients are the patients who you think are benefit from these devices. And 900 patients were including the trial, 400 patients in each, 446 patients in the device group, 442 patients in the control group. You can see here that 54% of the patients received the Watchman device. Almost 44% received like the Watchman Flex, the new device, and 41% like received the amulet device. So there was a lot of like new devices implanted in those patients, evaluating those patients. Looking, you can see here this 94% of the patients got the assigned treatment in the device group, but only 76% received the DAPT. I told you like about the design of the trial. In the control group, 85% received a DOAC. So what you find is that the primary endpoint, non-inferiority, was not met. Why is that? Because the p-value was 0.44 and they crossed the pre-specified criteria for this. Was the non-inferiority was not met on those patients. But however, like they also like found like major bleeding in the device group. 70%, 80% was related to the procedure versus 52% not related to the procedure. But they assume like 61% in the control group was 13.8% higher than the DOAX trial. That's what like they assume that. So no inferiority was met. Major bleeding was in 18 patients, 5.7 patients per procedure. So there was a lot of like safety events as well, a lot of the serious adverse events. Now, overall, the closure trial, patients who had like higher risk of bleeding, higher risk of stroke, those devices was found to be not non-inferior, meaning there is no evidence to recommend it up to this point. The champion AF is ongoing, meaning because in 5 years they are going to reevaluate the data. They only including like Watchman Flex. The other trial included all the devices, Watchman Flex, Watchman 2.5 Amulet versus NOAC. They specify that are like the new oral anticoagulations. And why they recommend? They recommend NOAC plus aspirin, NOAC monotherapy of that for 3 months after the device implantation, and then like aspirin on or P2Y12 inhibitor, basically Plavix recommended. And they evaluate at 4 months the perivalvular leak based on the TE on CT. Why CT and no TE in all the patients? Because during this point, like COVID was rampant, so they wanted to avoid COVID infections. And they followed for 3 years. They included 3,000 patients, and that was done in 16 countries. The other trial closure was done only in Germany. They included high risk of bleeding. Exclusion criteria was MI, stroke, TIA, or like a major bleeding event. What was the endpoint? Compensate of death from cardiovascular causes, stroke, systemic embolism at 3 years. They also included like a primary safety, non-procedure related bleeding. Remember in the closure was a lot of bleeding related to that, but they assumed like also was 13.8% more bleeding than the DOAC trials. Secondary endpoint was safety, and they are going to evaluate the data in 5 years. Was intention to treat analysis still, and non-inferiority margin was 4.8% with a relative risk of 1.4% at 3 years. This is important. What is non-inferiority margin again? Non-inferiority margin is tell you like how much worse I am able to accept to this new device versus the old treatment, the anticoagulation. In the protect was 2%. This expand to 4.8%. 4.8%. And the average chatbot score was 3.5%. The Hasbled was 1.3%. This is a different trial. Why? Because in the closure trial, you include patients with high risk of stroke and high risk of bleeding. In those patients are less risk of a stroke and less risk of bleeding. Those patients who commonly are recommended to use anticoagulation. So you want to see like the anticoagulation, if the device is good for those patients. And those are for also like almost 70% are paroxysmal, and previous ablation is 50%. What does that mean? Most of those patients probably are in sinus rhythm. When you are in sinus, less risk of stroke. So They included 3,000 patients, 1,500 patients in each device group. They found like a 90.8% was successfully deployed. And they found like in the discharge successfully device deployment, 85% received NOAC and 12.6% received that after the deployment of that. And the device group, 70%, 76% successful implementation in adherent to meds and 87% to anticoagulation group adherent to medications and follow-up. So meaning like there is a high adherent rates to what you intended to do. So what they found? They found like was non-inferiority was met. Why? Because of this. Because like the non-inferiority was 4.8 and they didn't cross 2.6. However, when you see the hazard ratio is 1.66. So critics says like non-inferiority was not met because crossed the 1.4 that was previously established was 1.66, although the non-inferiority margin was not crossed. So look there again. In the difference 95% confidence interval is 0.9 and is minus 0.8 to 2.6, and the non-inferiority margin you established 4.8. So non-inferiority was met based on this. By the way, the non-inferiority, remember, was 2.0 in the PROTECT, so it was higher, and they expanded non-inferiority here. So although the non-inferiority was met, but looking at the hazard ratio was 1.2 from 0.87 to 1.66. However, the relative risk it was 1.4. Non-inferiority was not met, although they claimed to be met, or was not met. Also, like safety procedures, would they find like superiority? So at this point, like they did also sensitivity analysis, and basically at this point, I don't think like this matters too much. Why? Because non-inferiority was not met. So the final slide is like right now is 2A recommendations in patients with atrial fibrillation moderate to high risk stroke, CHA2DS2 score more than 2, in contraindication to long-term anticoagulation, percutaneous left apneic occlusion device. This is going to change guidelines. I doubt it because we need more data. Although like they claim non-inferiority was met, actually it didn't. Closure device showed that in patients with high risk stroke and high risk of bleeding, non-inferiority was not met. So in this patient, we have probably to take a step back and analyze further data. We need more information about it to like change guidelines. And this is the data. What do you think? Leave me your comments down below. We can discuss further. Thank you so much.